Hi, everybody. My name is Ellarine Sanders, and I'm the Executive Director of NHCGNE. And it's our pleasure to have with us today Dr. Letha Joseph as our speaker. And she is the Geriatric and Extended Care Nurse Practitioner Residency Program Director and the Perioperative Optimization of Senior Health Program Manager, and several other positions, it looks like here in my notes, from the Durham VA healthcare system. She is a distinguished educator in gerontological nursing, and it is our pleasure to give her the floor for her presentation today.
Hello, good afternoon, everyone. Let me get my slides pulled up. Thank you all for joining for this evening session. Okay, I think you are able to see my slides, no? Yes. Yes. So it's an honor to be in the company of great colleagues like you who have dedicated your careers in advancing the care of older adults. Today, I like to bring our collective focus to Patient Priorities Care, or PPC, an approach grounded in the idea that best care for older adults, especially those ones with multimorbidity, starts not with their disease conditions, but with what matters most to them. So Patient Priorities Care is such an approach, and I was fortunate to be leading the implementation of Patient Priorities Care along with Dr. Eleanor McConnell. Maybe some of you might be knowing Dr. McConnell. She is a pioneer in several aspects of gerontologic nursing, geriatric care. So this is a project funded by the Veterans Health Administration's Office of GEC and GRECC. So a few years ago, I was the primary provider for Mr. Thompson, a 89-year-old veteran with heart failure, COPD, diabetes, and chronic kidney disease, and several other conditions. His medication list was very long. His specialist visits and medical appointments were too many. When I asked what mattered to him and what makes him happy, he said simply, I want to be able to walk to my neighbor's porch and every evening and sit down there without feeling breathless. No one has ever asked this veteran what he really wants to do or what makes him happy. In fact, nobody had asked him about it. So this question and this answer from Mr. Thompson was a life-changing experience for me, by the way. And our care team was able to revisit the treatments and activities taking place for Mr. Thompson. I was able to reduce some of the referrals and consultations, and the team modified the treatments, and it really made a big difference in Mr. Thompson's care because we were able to align the treatment, therapy, everything around the goals of Mr. Thompson and what was making him happy. So focusing on outcomes for individual diseases is less helpful for people like Mr. Thompson, especially who are with multiple chronic conditions. For example, what is good for their heart may not be good for their kidneys and vice versa. An unintentional harm can occur when we are considering individual disease conditions and managing them in silos. So PPC, or Patient Priorities Care, moves decision-making away from the siloed disease-based care to focus on patients' health priorities. PPC approach can be used to reconcile decisions when there are different perspectives, either among clinicians or members of the healthcare team, or among clinician, patient, and the care partners. It is the care aligned with patients' own health priorities. And we all know about the age-friendly health systems, and what matters to the older adult is a focus of our improving care. That approach is appropriate for everyone, but particularly for patients with multiple chronic illnesses, functional limitations, cognitive decline, etc. PPC approach is not a one-time done it all situation. It is an ongoing process because over time, patients' priorities change, their disease trajectory changes, and their goals changes. Though values might stay same, but the goals and what they really want to do changes. So PPC process has 5 steps. The first one is identifying values and what matters to the patient most. So value, we actually look into 4 domains when we are following the PPC approach. 4 domains are connecting, enjoying life, managing health, and functioning. I'll go a little bit on each domain. So in connecting, what relationships and connections are most important to this patient right now? It might be connecting with family, community, etc. And maybe the patient is able to identify most important people or most important groups in their life right now. It might be their grandchild, or it might be a group of similar people who were in the Air Force before, or maybe church community, something like that. And how this patient feels meaning when he or she is considering that connection. What interaction will make them feel that they are maintaining or recreating that connection? Enjoying life, it could be recreation, or maybe some meaningful, productive activities like volunteering. So questions like, what brings you the most enjoyment? What is that one thing that gave you the most happiness, most enjoyment? What you would be doing if you were having a good day? So that is the second domain. Next is the managing health. So what do you hope your healthcare can do for you? Where does this person balancing the quality of life and the quantity of the days he is going to get? What treatment this person likes to take, even if it is bothersome? How much symptom management this person wants to focus on, and how much effort really this person wants the healthcare team to put to improve or prolong his longevity. The next domain is functioning. So how much independence this person really is looking after or looking for, and what is self-care meant to this person? How much care this person is willing to do for himself or wanting to do for himself, or letting others doing for him? And what is the definition of dignity for this person? Are there some things or certain things at any cost this person wants to do for himself so he feels independence and dignity in his life? So that is the first domain, or the first step. We address these 4 domains, ask questions to identify, tease out what matters to this person. The step 2 is creating health goals which are realistic, specific, and actionable. So once we know these are some of the value domains the patient identified, so we are helping this patient come up with activities where they can be connected or fulfilling this the first step we identified. So if the person has some connection wanting to maintain with people, it might be with the family members. So if connecting with the family is important for this patient, how can he connect? Is it by doing a telephone call every evening, Or is it by having in-person time with them? Maybe every day, or maybe once a week, or maybe twice a week. So identifying that realistic and also achievable and the same conditions. Maybe the person wants to be involved in the community. So involving in the, getting or being involved in the community can be different ways, but which is one way patient wants to do. It might be volunteering in the nearby library for stacking the books, and also it might be once a week, it might be twice a week. So if the patient is telling, I just want to be more independent, that's not a clear, or because it's a broad statement. So again, asking questions, what activity will make you feel that you are, more independent? Or what does independent look like you? Because for me, what is independent may be just for me. It may not be the same definition for someone with physical activity limitations, right? So ask for specific details and clarify exactly what the patient wants to be doing by being independent. So that will help us help this patient create specific and actionable goals, and we will be able to help them come up with a plan. Unless the goal is completely unrealistic, do not dismiss by saying, like, yeah, when you were young, you were able to do that. Now, I don't think you can do. No. If there is some way of modifying and accommodating, probably patients might need some redirection. So do that. And now, if patient is bringing a very unrealistic goal, like, if patient is almost bedbound and telling, like, he wants to walk a mile, or some very unrealistic goal, ask this question, like, okay, let's talk more about it. When was the last time you were able to walk this 1 mile? So maybe that conversation will go further to make the patient realize that the goal is not realistic. So we are coming to the step 3. Step 3 is reviewing the symptoms and health problems. So, in this, we are reviewing the patient's symptoms and health problems to determine what may be interfering or what could be interfering with this patient's goal of achieving what we talked about in step number 2. So it could be some bothersome health problems. So identify, ask patients about what symptoms interfere with the goal. If the patient wants to be walking to the neighbor's porch, so what are some of the things which are preventing you from doing that walking? It could be knee pain, it could be feeling tired, or it could be feeling short of breath. So finding out how we can modify the treatment, or how we can modify this person's routine so they can achieve what they want to do. So that is taking us to the step 4, where we are reviewing the healthcare tasks and medications. So get a full picture of patients' healthcare and what matters most. Ask how they feel about the healthcare task. The patient who is checking blood sugar for 4 times a day, before breakfast, before lunch, before dinner, and at bedtime, probably that is something which is really a bothersome healthcare activity. So how we can modify that? Maybe it is by modifying their insulin regime, right? Or maybe going with the continuous monitoring of blood glucose. So how identifying what is really a bothersome healthcare task help us revise the plan. So with this information, we can help them find a balance between what they are able to tolerate in terms of healthcare activity or healthcare treatments. So speaking of healthcare task and trade-off, find out what are some of the helpful healthcare tasks they are doing it, how much they are able to do, how much they are willing to do. And some of the burdensome care, maybe they want to give it up, or maybe they are still able to take it, which is called a trade-off. so that they can achieve their specific goal. If a patient who is not willing to take their diuretic pill in the morning because the patient doesn't want to go to the bathroom back and forth and he is not feeling good about taking it, but his goal is to be be energetic and being able to stay awake and active when the grandchildren are coming home in the evening, probably explaining that taking this medication in the morning help you urinate and you will be energetic when your grandchildren are coming home. So they are able to make that trade-off because that helps them achieve their goal. So PPC is not an approach just to deprescribe or um, reducing the care or reducing the treatment, but it is also for improving the adherence, because patients' values are taken care of and their goals are identified. And if we are able to tie the specific activity, patient is unable to tolerate or unable to or not wanting to undergo the trouble of this treatment, we can, with the explanation, we can improve the adherence. So ask some specific questions like what is working well, and if you could change one thing about your healthcare, what it would be. What about your healthcare which is really bothersome, and what is something best you will be doing if you are having a good day today, or if you are managing your healthcare conditions well. So all these questions give patients an opportunity to make their voice heard, and it gives us an opportunity to balance their desired health goals as well as the treatment that which will help them reach there. So that is bringing us to the last step, which is choose the one thing to focus on. What is that one thing? This one thing is either a health problem, or it could be a burdensome task, or it could be some activity they want to do. So what is one thing that you want to most focus right now in your healthcare? Tie that one thing with their health goal. That is what I was just telling, how it helps us improve the adherence. There was a patient who doesn't want to take the sleep apnea, the CPAP machine, because it was not a comfortable thing for the patient to tolerate. But the patient was feeling so tired and sleepy during day. But once we were able to tie getting a good night's sleep along with good oxygenation and improving that feeling of energy and strength during daytime, patient was able to go back and try, or wanting to go back and try. So as I just mentioned, identifying what matters to them and tying the treatment and healthcare task with that might improve their adherence to difficult or burdensome situations. I have a case example here, and the Mr. Robert, who is a middle-aged male with neuromuscular disease, that is the ALS, and he had intact cognition. He was DNR. He was a nursing home resident, and he was requiring physical total care, bedbound, and everything. He was having recurrent urosepsis because of an obstructing urethral stone, and he had a stent which was getting managed by changes and all. And he knew, or he was told, that a lithotripsy can be probably a definite treatment. However, the surgeons were reluctant because they thought he may not come out after that ventilation because of his ALS. So patient really wanted the procedure. The surgeons and anesthesia didn't want to kind of like move with that. So we applied the PPC approach for this patient, and his value was kind of like, connecting with people, familiar people. So he was in the nursing home where he was thinking that is his family. So he wanted to be there, and something he wanted to avoid, that was hospitalization. When he gets urosepsis, he is going to the acute care and ending up in intensive care unit. So the helpful task was, or helpful treatment he identified and everybody identified was, surgery or the lithotripsy. The bothersome was the managing his UTI and being in the ICU. So he decided to make the trade-off, like taking the anesthesia risk. So with this discussion, we were able to convince the anesthesiologist and the urologist, and patient had his procedure, did not have any complications, went back to nursing home. After a year, he died. So I know this was not the answer for making him live, live longer. However, his goal of being in the place, the familiar place, and dying there rather than having sepsis and needing to be in the hospital, that was one thing we wanted to focus on, and it was focused on. So this is the nutshell approach of patient priorities care. And those who really wanted to learn more about it, please visit the Patient Priorities website. It has a lot of information, including several modules to take, which will walk you through the process more in detail. Also has a lot of resources which you can use for your patients. And I am happy to continue the discussion. And if we want to come back and hear about how we implemented in my facility, I'm happy to do that also. However, for the interest of time, I am opening this floor for discussions.
Thank you, Dr. Joseph. We can either, I can identify hands if hands are raised, or we can use the chat for discussion. If there aren't any questions, do you want to go back to your slides? Was there, I know you had more slides than we presented here.
Yes, I do have slides where I'm talking about how we were able to implement it in our place and what was the outcome. Okay, so let me go back to presentation sharing mode. Are you able to see my screen?
Yes.
Okay, so we are in the second year now. So the first year, how we started was we had some PPC facilitators training. So the trained PPC facilitators, they created facility-specific patient workbook to guide this conversation. And then we created templates for documentation in our electronic health record. And also we had this dashboard. Truly speaking, the template and dashboard, it was easy to create because nationally these templates were created. So it was there in the VA system. And even the dashboard. So we really needed to tailor for the local use and then have it get set ready. So after the training and after having all the documentation pieces created, we introduced this PPC to all our providers. And nurse practitioner residents, the last year NP residents, three of those residents, they took the lead in getting this PPC approach to the patient. So they introduced this PPC during their encounter and distributed the workbooks in the clinic encounter. Then they called the patients and completed this discussion and documented the encounter. Then revisited their plan they revisited patients' goals during their next appointment or during this telephone appointment and adjusted their patient's plan of care. And also, by looking at our PDSS cycle, we were able to adjust the process. Adjustment of process took us to, instead of sending the patients with booklet and then making the telephone call later on, to providing these booklets and then walking them through this discussion in the clinic and making the documentation. Then we decided, okay, so our PDSA went well, and we were able to see where we needed to fix the actions. So after that, we decided to take it to the next level of our interprofessional group. So these are the pages from our workbook, and I don't know whether you are able to see it very well. So we are setting the goal and then identifying the domains, and then setting the goal, and then checking what are the bothersome things, and then the same thing which I was explaining here. So from that, for example, an encounter will be the Friday afternoon, the veteran arrives at the Geriatric. Geriatric is Geriatric Clinic, and it is Patient Aligned Care Team. That is the PACT stands for. So at the end of the visit, the NP resident discusses PPC with the veteran and the family. And so Geriatric Clinic serves veterans who are really old and with comorbid conditions. Several of them, or at least more than half, they have dementia at various levels. So if they are interested in participating, they're given booklet with the instructions, and then following Tuesday, they were calling them. That was the initial approach. And then we documented it in CPRS. So in year one, when we had all the structure in place, so I could say that we had 4 months to do it, and we had 40 unique visits, and 27 patients were served with this patient priorities approach. And some of the lessons we learned, it is more challenging than it sounds, okay? And we addressed these challenges through rapid cycle change approach, and we realized that flexibility is the key. Maybe we will call the patient, and maybe patient is not ready with the booklet. So then we decided, okay, 30 minutes before we call them to do the actual PPC conversation, we will call and tell that, okay, we are going to call in 30 minutes and be ready with your booklet, and those sort of. So flexibility is the key, and patients really, really appreciate it. Some people said, like, we never thought that such questions will come to our healthcare visit. So they really felt more connected with the providers who asked these questions, and involving the family members. Some of the barriers, technology and time constraints, sensory deficits, when you are trying to talk to patients over telephone, and if they have hearing impairment, how difficult it is, or how challenging it can be. And cognitive impairment and complex multimorbidity. Also, we had questions and struggles. If patient wants to go this direction, how we can kind of like some of the conversation, so that we can uphold patients' values and goals, at the same time convince the specialist who is really wanting to correct that deformity, correct that heart block. So that was also another challenge. So year two. So first year we had only the geriatric primary care, and now we have additional 2 clinical sites. One is the nursing home part of the VA, and the second is perioperative optimization of senior health, or the POSH clinic. So we developed plans for additional tools, and then incorporated into the workflows. We had social workers started helping us together. And also we included the geriatric medicine fellows who are also learners. So, and the first year nurse practitioner residents completed their program and left. So now I have the 3 current NP residents, and one of them, I thought I saw Ruth. Yes, Ruth is here. So they are actively doing it. And then aligning care, that is what we are focusing more on. And now we are getting an opportunity to implement this PPSC system-wide, because you all know that in 2025, CMS came with including the age-friendly approach for the required criteria. So our facility parallelly started an approach to go that age friendly, and then they had been connecting with us, Dr. McConnell and myself, on getting this PPC approach worked out for inpatient areas. That means all the inpatient units of our hospital will follow this, because this template we are using has all the health factors to address all aspects of age-friendly healthcare. So that being said, for the second year, this is a screenshot from the dashboard. That's why it is looking a little dark. So we had 125 unique visits and 109 patients. So these 3 bars, one is the light blue is identifying patient priorities. The purple one is how many patients had patients priorities follow-up, and the red one shows how many patients identified their one thing. So that is the end of my slides and our success story, I would say. And we were able to, last year, we were able to present it as the PALTC National Conference. This year, we were able to present it at the AGS, both as posters, and dissemination continues. And more than getting the numbers up, change that shift in the way clinicians think and addressing what matters to patients.
Thank you, Dr. Letha. Now I can't see your Dr. Joseph. We really appreciate you presenting for this fireside chat, and there are some questions in that people have put in the chat, so I will send those to you, and we can do a follow-up if you want to do anything with those. We'd like to invite you to come to our August fireside chat. Tom Blodgett will be our speaker, and his topic is a delirium simulation for acute and primary care NP students. So that should be really interesting. Thank you all for attending, and we will see you next month.
Thank you for all joining, and NHCGNE for this opportunity. I had someone asking for the slides. I'll be happy to, if you could, give me your email ID, or I think these are going to be, the recording is going to end up in the NHCGNE website, but I'm happy to send the slides. But let me tell you, go to that Patient Priorities Care. There are a lot of resources available for VA and non-VA providers and clinicians, and their goal is to get it everywhere. And if your facility wants to do something, a lot of mentoring available. I don't know about the funding, however, mentoring is available, training is there. They do the facilitator training periodically. So, and they're happy to teach everybody. So make use of that. Yeah, I'll be sending, I got the email ID for Miss Patricia Pokrant, and I'll be sending the slide. Yes.
Thank you, everybody.